Hi, my name is Nick Tutticci. Today I am discussing our study, the characterization and significance of protrusions in the mucosal defect after cold snare polypectomy. This research was undertaken whilst completing an advanced endoscopy fellowship at Westmead Hospital, Sydney, Australia. Colorectal cancer mortality and incidence is reduced by colonoscopic polypectomy. The majority of polyps are small in size, and cold snare polypectomy, which has cost and safety advantages over conventional polypectomy, is increasingly performed worldwide. Pale protrusions may be seen on occasion within the cold snare polypectomy mucosal defect and are yet to be characterized. Given the striking appearance of these protrusions at times and the lack of knowledge about them, it is not surprising that there has been conjecture around their constituents and their significance. Anecdotally, the projections have been labelled as large denuded vessels, residual polyp tissue, or condensed submucosa, and we have heard of colonoscopists routinely re-snaring or clipping protrusions when they occur. Clear characterization of this occurrence is therefore imperative. The aim of this study was to examine the frequency and predictors of occurrence and the histologic constituents of cold snare defect protrusions, CSDPs. This was a prospective observational study performed at a tertiary care endoscopy unit, Westmead Hospital, Sydney, Australia. In this institution, cold snare polypectomy is the predominant method for polypectomy for lesions less than or equal to 10 mm in size. Cold snare polypectomy was performed by a standardized technique. A hexagonal-shaped, thin, stiff wire snare was used to resect the polyp, including a 1 to 2 mm margin of normal colonic mucosa. We believe resection of a margin of normal tissue is mandatory during cold snare polypectomy to ensure complete resection. Specimens were retrieved with suction in the mucosal defect, interrogated with high-definition white light after washing. Any elevated area within the defect was defined as a protrusion and was biopsied using large capacity biopsy forceps. The tissue was submitted separately to an expert GI pathologist. Cold snare polypectomy was performed for 257 polyps in 88 patients. A CSDP was identified in 36 patients, prevalence 14.4%. On univariable analysis, protrusions were associated with lesion size greater than or equal to 6 mm, but not sex, location, polyp parasmorphology, or serrated histopathology. This association persisted on multivariable analysis. Histopathologic assessment of the CSDP revealed submucosa in 95% and muscularis mucosa in 80%. Elements for both layers were seen in 78%. No residual polyp tissue, either serrated or adenomatous, was seen in any biopsies. Minor intraprocedural bleeding was seen in 2 patients requiring clip placement. One of these patients had a protrusion, whilst the other did not. No adverse events were identified in 30-day follow-up. To summarise the findings, CSDPs are a common occurrence in patients undergoing cold snare polypectomy and are associated with polyp size greater than or equal to 6 mm. They are predominantly composed of submucosal and muscularis mucosal elements. They do not contain residual polyp tissue or large vascular structures. In general, this study therefore provides reassurance to colonoscopists. No additional therapy such as clipping or snaring is required based on the occurrence of protrusions alone. We anticipated the finding of submucosa, but not that of muscularis mucosa, which was seen in the majority of protrusions. Muscularis mucosa is a component of the mucosal layer, hence residual muscularis mucosa represents incomplete mucosal layer resection. The significance of this remains unknown, particularly when advanced histopathology is encountered. There has been no systematic study of routine resection depth in cold snare polypectomy to date. Furthermore, the frequency of residual muscularis mucosa and bland cold snare polypectomy defects was not assessed in the present study. This study was performed in a single tertiary endoscopy unit by experienced colonoscopists. a single snare design was utilised, and a standardised cold snare polypectomy technique was applied. Any of these factors may have influenced the findings. Further study in this area is required, particularly around the routine depth of resection achieved by cold snare polypectomy, the influence of snare wire design, and implications of incomplete mucosal layer resection in the setting of polyps containing high-grade dysplasia. Thank you.